Чи мене чутно? Мені здається, що ні. Мені здається, нема в мене звуку. Чи є? Йорг, ви мене чуєте? Професор Фегерт, чи ви мене чуєте?
Yes, I can hear you.
Так, я вас чую, звичайно.
Добре,
Чудово.
я чомусь в себе чую переклад, не знаю чому, але зараз, може, мені щось там виправлять, і я буду чути тільки спікерів. Дякую. І так, добрий вечір всім. Ми дуже раді бачити Йорга Фегерта, який для нас все це організовує кожного разу. І все ще до нас приходять нові і нові спікери, за що ми дуже вдячні пану Йоргу Фегерту. Ми не знаємо, ще приєднається до нас пані Оксана чи ні, бо вона десь в дорозі і все буде залежати від її зв'язку. Я маю на увазі пані Оксану Збітнєву, керівницю координаційного центру Кабінету міністрів України. І я попрошу Йорга представити нашого спікера, і потім я зроблю ще декілька організаційних оголошень. Прошу, Йорг.
Thank you very much, Katja. It's a big pleasure to introduce Tom Osborn to you. He was a special guest of ESCAP, of the European Society of Child and Adolescent Psychiatry, at the ESCAP Congress in Strasbourg as a keynote speaker, and he really impressed us all. He is the founder and CEO of Shamiri, Africa's largest youth mental health provider, serving over 100,000 young people annually. He's widely recognized for his leadership in social innovation, community building, and entrepreneurship. Tom is a fellow of different organizations. He was honored by Forbes 30 under 30 on the global level. And what I really admire is what he did with his initiative, because he really was able to reach out to many, many young people needing psychosocial support. And doing that in Kenya, I think that was a difficult task, but he really has a very good example. And if we think about Ukraine, and we often talk about the psychosocial needs you have with the campaign, how are you? There are so many kids that need help and attention at the moment. I thought it might be wonderful to hear from an entrepreneur, somebody who really tried to change the world with his means, about how he did it. He is a committed researcher and innovator. He has led multiple research projects, securing over $5 million funding, and he has authored more than 50 peer-reviewed papers in leading journals, including JAMA Psychiatry, the British Medical Journal, World Psychiatry, and the Lancet. He's also the co-author of What We Can't Burn, a memoir on friendship, fiction, and the global energy transition, because he also was dedicated to global environmental questions. So his dedication to community and challenging the status quo is deeply rooted in his upbringing in rural Kenya. He attended Alliance High School and graduated with high honors from Harvard University, and he now lives in Nairobi, where he continues to work at the intersection of social innovation, community empowerment, entrepreneurship, and system change. And today, he will talk about his Step Care Youth Health project.
Дякую, Йорг. В мене буквально парочку організаційних таких питань, і потім ми перейдемо до Тома з його презентацією. По-перше, всім нагадую, що ви можете задавати питання, і ми наприкінці презентації будемо їх задавати. Я їх буду зачитувати, перекладачі будуть їх перекладати, і Том буде відповідати. Якщо Йорг ще буде з нами наприкінці ефіру, то Йорг теж буде коментувати і відповідати. Ще всім нагадую, що нас можна дивитись на каналі доктор Булавінова, а також на Фейсбуці Координаційного центру. Будь ласка, підписуйтесь як на Фейсбук Координаційного центру, так і на канал доктор Булавінова, а також на мій Телеграм, де ви отримуєте інформацію, також як і в емейлах, про те, коли наші наступні події. Тобто, будь ласка, підписуйтесь. Ще раз нагадую, любі питання ви можете нам задавати, тільки наприкінці ми будемо на них відповідати. І наразі попрошу операторів вивести на екран Тома і презентацію Тома.
Can you hear me? Okay, I just lost the channel too, so I'm trying to...
We can hear you very well. We hear you very well.
Yes, we can hear you.
We hear you very, very well.
Okay. I can't hear the translator, though, but it's okay. So I'll just continue as we figure this out later. So ladies and gentlemen, thank you so much for having me all the way from Kenya. It's really exciting to be in this call today and this webinar with all of you. And a lot of the ideas we're going to share about mental health, especially from the perspective of Kenya, as Professor Jörg said. I think that there are a lot of similarities and lessons universally, that we can be able to learn and, hopefully apply in the Ukrainian context. So thank you so much. And, feel free to share your questions, which we will answer towards the end. So today I'm going to be talking about this idea of stepped care within youth mental health. And I'll split my talk today into 3 parts. So the first part, I'll talk about just the infrastructure and the theoretical underpinnings of what stepped care can look like. In the second part, I'll give a more concrete example from the work we have been doing in Kenya in implementing stepped care mental health approaches. And then lastly, I'll talk about how a lot of the recent advances that we are seeing, especially with digital mental health, and especially with artificial intelligence within the mental health space, can be incorporated within this stepped caregiving model. So that's a little bit of the picture. And once again, if you have any questions, feel free to share them, and I'll try to answer as much at the Q&A. So the global challenge that we have is a treatment gap. So many young people are in need of mental health interventions and mental health care, but most of them don't really receive it. So the global estimate is between 40 to 60%, but in Kenya, where I work, about 80% of young people who need access to mental health interventions don't really, access it. But when we think about this problem, at least from our perspective, we see this as not being a knowledge problem, but mostly being a delivery problem. So we do increasingly have a wide array of interventions that are effective that exist. We do increasingly have an increasing amount of providers who are available. But the challenge is, how do we harness existing interventions and existing providers and systems that we have to reach as many people, as possible. So at least, that is how we think about the treatment gap. imagining the barrier not being about what we know. Over the last 50 to 100 years, we've seen an increase on evidence on the effectiveness of different type of interventions, for example. But it is more about reimagining how care is delivered, by whom, and at what cost it is being delivered. And the reason why this is crucial is because more broadly, you can put the challenges that drive the treatment gap into two big buckets. The first is that we don't have enough providers everywhere, like across the whole world, be it in Kenya, Ukraine, Germany, for example. We just don't have enough providers, and so that's one of the reasons why we have a treatment gap. And then the second one is a lot of the interventions that we have, which are effective, tend to lose their potency or efficacy as they are scaled. So as we move them from research context or clinics, and we move them into different contexts in the real world, as we change who delivers them, we tend to lose efficacy. But over the last 2, 3 decades, we have seen some advances that can solve these two problems. So the first one is this idea of task shifting or task sharing. And basically what this refers to is you can be able to train non-specialists to deliver effective evidence-based treatments for mental health. And this idea originated initially from primary health in the developing world, where they didn't have enough doctors, with primary health. And so they started training, for example, folks who they call community health practitioners to do things like screening for malaria, or screening for tuberculosis, or delivering, vaccines. And there was a lot of success with this task sharing model in primary health. And since the 2000s, we've started to see a lot of its application in mental health as well. One of the first examples of this actually happened in Uganda after they had a war in the late 1990s, early 2000s. And they trained a group of community health workers to deliver interpersonal therapy. And they saw that it could work, within this context. And since then, we have now seen a lot of evidence for this across different types of problems, be it PTSD, depression, anxiety, substance abuse, etc. And this is actually now like a WHO, recommended approach in helping reduce, like the provider gap. And the second advance is we have seen an expansion of the quote unquote treatment toolkits beyond traditional therapy models like cognitive behavior therapy or interpersonal therapy. For instance, we've seen a lot of like transdiagnostic intervention approaches which move beyond, trying to treat one disorder and building a protocol, for one disorder, to trying to address multiple issues, simultaneously. We've also seen a lot of quote unquote strengths-based intervention approaches, which rather than focusing, for example, on treating the psychopathology or the negative parts of, let's say, depression, focus on improving strengths like resilience, gratitude, growth mindset, etc. And we've started also to see, kind of a lot of different type of approaches beyond just one-on-one therapy. We're seeing a lot of like group-based work, for example, or universal, school-based work. And over the last 10, 15 years, also a lot of like digital, brief and single session, interventions. So we are now starting to have like a much broader toolkit of interventions that we can use. And we are also having a much diverse, quote unquote workforce that we can use to solve for this provider, challenge. And so the beauty of these two recent advances is that they allow for and support what we call stepped care models, right? So they allow us to begin to imagine a care model that takes advantage of this broad intervention toolkit that we have and takes advantage of, a broader, provider workforce to make care more accessible and also more responsive to different people's needs, and in theory this is how kind of like a stepped care approach may work. So at the very bottom you can imagine universal intervention type approaches, and these can include sorry, I just lost my screen. Just a minute. Yeah, and this can include, for example, like single session digital intervention, psychoeducation, self-help, etc., as, like the first layer of preventative, care approaches. And then as you go up, you start to have folks who have quote unquote low intensity needs, so they have like maybe mild to moderate severity of symptoms. And they could benefit from, certain types of interventions like, strengths-based interventions or grouped interventions, which can be delivered, for example, by trained lay providers, rather than by psychiatrist or psychologist. And as you go up the stairs, quote unquote, folks with moderate intensity needs, can get more traditional, individual therapy, structured support, and eventually, specialists can deal with really high intense, super complicated cases. And so the reason why, at least theoretically, we think this model is really exciting is it allows us to do two things. It allows us, one, to, in theory, provide the full spectrum of care, from preventative care all the way to like specialized care, with clear referral pathways for both escalation and de-escalation. But also more importantly, it makes access to care accessible for people, as we will see later in the presentation in the context of Kenya, you can do universal and low intensity interventions in schools. You can do universal interventions, digitally, all within the stepped care model, ensuring that for folks who actually have severe needs, you're able to escalate them, up and down. So I'll now switch to the next part of the presentation, which is going to be oriented around, trying to paint a more concrete picture of how this theory and idea of stepped care looks like in the real world, using the example of the work that we do at Shamiri. So the way we've envisioned the stepped care model at Shamiri and what we are now implementing at least to 100,000 young people every year has three fundamental, tiers. So I'm trying to see if I can annotate. Yeah, so basically the first tier is low intensity care. And basically here, what we do is we train 18 to 24-year-old high school graduates. We train them for about 10 hours. It's a very brief training. And then they deliver group-based interventions that I'll talk about later as the first level of care. So there's a first level of care for young people with mild to moderate symptoms. It's done by these folks who we call Shamiri Fellows, who are just young people who only have a high school degree, who've only been trained for 10 hours, and who then, kind of like lead these group sessions. And that's the first level of care. And the second level of care, we have folks who we call clinical supervisors. And so they are people who have some mental health background, so either they have a bachelor's degree in psychology or counseling, or they've been working as social workers. And they basically do three things. So the first thing that they do is that they train and supervise the first tier. The second thing that they do is they are on site during the group sessions to provide, supervision and quality assurance. And then the third thing is they actually do one-on-one therapy for, folks who have moderate to, mildly severe symptoms, and so they will be trained for longer to do like or IPT or CBT or something like that, for folks who need, escalation. And then eventually you have the third tier, which is where you now have your licensed psychologists and your psychiatrists. And basically, kind of what they do is they now handle all of the complex cases. They provide clinical oversight overally. They, are in charge of like the referral pathway, etc. And so basically the idea behind this model is now we have a pathway, from both universal preventative care, to more elevated care, both upwards and also, downwards. And what we have here as tier zero, I'll talk about this later, but basically for us now as an organization, because this model is actually really simple, to do, but the key behind it lies in being able to build the infrastructure to support it, the infrastructure to be able to train these fellows, do the referral, etc., work with teachers, work with government. And so on a day-to-day at Shamiri, that is what we do, building this infrastructure to then allow, schools and government systems to be able to implement this, three tiers of care. And let me just cancel this. Yeah, and so let's now talk a little bit about the type of interventions that we use in tier one. So at the tier one intervention, we mostly focus on, what we call strengths-based interventions, so they're very simple interventions, so it's a 4-week group session that everyone goes through in tier one. And session one and session two covers growth mindset, so it covers this idea that our abilities are not fixed and they can change, through hard work and effort. And so we introduce this concept. We go through personal growth testimonials. We learn how to use this concept for problem solving, right? And then in session three, we talk about gratitude. And for in our context, the reason why we do gratitude is because a lot of the young people we're working with are coming from very, difficult socioeconomic background, and so most of the time they don't really recognize that there are a lot in their lives that they can actually be, grateful for. And, and we also do have a lot of research that, practicing gratitude is also just good for your overall, like well-being. And then in the session four, they learn about values with the intention of like understanding what their sense of purpose is, and also using this, kind of as a problem solving tool. And the reason why I'm spending some time on these interventions for the first tier is just to highlight how you can leverage this expanded, treatment toolkit that I was talking about initially, which now includes this type of simple interventions for which we do have a lot of evidence that it works. And a lot of these interventions, because of their simplicity, can be completed and conducted by lay providers very simply, right? So the reason why we only train them for 10 hours is the training covers three components. So the first one is just like basic group leadership skills, so things like active listening, etc. The second part is we talk about the didactics or the contents of the intervention. But as you can imagine, almost everyone already has an idea of what gratitude is or what values is, right? And so because of that, we can shorten the training. But the crux of the training happens during role plays, where young people lead mock group sessions, before they go out to, like lead actual group sessions. Yeah, so so this basically just highlights how the escalation and referral pathways works. So you do the screening and intake, and for about 80% of the young people we work with, at baseline, they will have moderate or mild to minimal symptoms, so they can go through the group sessions. If there are flags which are arising either within the group sessions or through continuous monitoring, you then do the step-up triggers, which either move them to the tier 2 care, or to the tier 3 care, right? And some of the step-up triggers can be things like, persistent symptoms, suicidal ideation, etc. But basically just like really mapping these out and building and modeling it and implementing it. So that's a little bit about how we implement this. And I will just be talking a little bit about the evidence that we have to support this work. And as Professor Jörg had mentioned, we've conducted a lot of like RCTs to just show that this approach does work, and I'll just like briefly talk about this at this juncture. So I'll talk about two RCTs in particular. So the first one was one we did in 2019 and 2018. It was an initial pilot study, and we did it with about 51 adolescents who were high school graduates. We trained them for 10 hours, as I mentioned, and we were basically looking at depression and anxiety, outcomes. And what we found in this pilot was like compared to an active control group, there was significant reductions in depression and anxiety. But to overcome the limitations of this first RCT, which was a small sample size and lack of a longitudinal follow-up, we did a larger RCT, actually across 56 schools with 413 adolescents. And here we actually followed up not just at the end of the intervention, but across the whole school year, so across 7 months. And we found also similar reductions in depression and anxiety. But for us, what was exciting is that we found that these effects are actually comparable to those of, traditional one-on-one delivered therapies, at least from what we found in like the benchmarks from meta-analysis in the literature. So those are the first two initial studies that we did in 2018, 2019, and 2020. But a big thing for us has been we have to find ways of doing this in quote unquote naturalistic settings. So what happens when other organizations, for example, we work closely with other NGOs or county governments, and they implement this model on their own. So when they do that, do they have generally, kind of like similar findings as we did in our trial? And what we've generally found is, across different, contexts, we find consistent reductions in symptoms across different implementation sites, further encouraging us that, this model actually can be translated from like research context, into practice. But really why we are super excited about this is the cost effectiveness, of it. And so just using the context of Kenya, a 4-week one-on-one session for therapy will cost about 125 euros. But our cost is actually just less than 8 euros, actually. That's what it costs us to deliver, this model, for everyone, right? And so that's, between 10 to 4x less expensive than what exists traditionally, whilst being generally, kind of like effective. And a big driver for this is because of the triaging and because you do group sessions and one-on-one sessions, etc. Once you spread that cost around, it becomes, kind of really accessible. And so that's one of the reasons where we are super excited to be working with government in Kenya to see how we can, be able to like scale this, throughout the country. And that's why we can be able to, serve 100,000 people every year, because the cost generally per client served are really low, right? And so if you were to do, like a cost effectiveness graph, you will see that, this type of tiered approaches are generally more cost effective, compared to what exists, out there. So one question we get asked a lot when we talk about task sharing and task shifting is around risk management. I think a question that we get asked is, when you're task shifting to different types of providers, are you lowering the quality? Are you introducing, different type of risks? And normally how I think about that is in two ways. So the first is I think of task shifting and task sharing not as lowering quality, but as expanding quality. And to give an example of this, in almost every primary health facility that you go to, there is some element of task shifting that is working. So when you go in, you'd have you'll have a nurse take your blood pressure and someone run a test on you, and you have a pharmacist, like who's in charge, of delivering, kind of like the prescription. And that is, task shifting and task sharing within that context. And we're just trying to do something, similar within a mental health, model. Like it doesn't make sense and it's not feasible, for example, for a psychiatrist to do the full continuum of care, from prescription to, psychoanalysis and one-on-one therapy, and follow-up, and tasks, kind of need to be spread out. And one can actually even make the argument, if you do that effectively, you're actually amplifying the expertise and the quality of care. So that's at least my initial response to why I think task shifting is a pretty great idea. But also more importantly, one of the things, so we now do have a lot of research and evidence about is around structured risk management, within care approaches. And so it's possible to also similarly build like a structured risk management protocol that can, like ensure safety. And this is just like a brief highlight of how ours work, from screening and risk identification to specialist consultation, and also like emergency, like services, right? And so some of the design principles is the supervision and training of the different providers is mostly on identification, but not clinical management. So to be more explicit about this, if there is something which needs to be escalated, we don't ask the non-specialist to do the clinical management of that. That is not within their expertise. All that we ask them to be able to do is to find ways of identifying this and flagging it, and escalating it, and then having the tier 2 and tier 3 folks be responsible for its clinical management. The second part is data becomes really crucial here. And one of the great things of being in an increasingly digital world is you can be able to build in place real-time data systems, which can also flag and support rapid, response. And so we've built a lot of this, and it's actually open source, and most of it is already published or is being published. And the hope is, different people from around the world can build on this and make it more relevant within their context, if they were to do, something simple. And lastly, on this part, one of the things we've been thinking about is scale. And the reason why I think thinking of this idea of scale is important for us is we recognize that the needs for mental health, especially amongst young people, is only increasing. So the prevalence rates are only increasing, and they're increasing because there are more and more emerging stresses, every day, conflict, for example, AI, like just the world is becoming more and more stressful. And so you're getting more and more young people who need care. And so we need to think about how do we scale up to be able to serve as many young people, who need it. And the examples I'm going to talk about are um, mostly Kenyan specific, though they can be able to apply in other contexts. But just like take it with that in mind. So when thinking about scale, we think it's important to think about how we are scaling from four perspectives, and we call this the four enoughs. And the reason why I'm bringing this up here is, unfortunately, the way we typically tend to work, and I think we've all talked about this in a lot of different contexts, is in silos, and so you have researchers who are talking in one, who are working in one context, and you have practitioners who are working in one context. And often when we do this, we don't, kind of get the full picture. And so the first one is around this idea of good enough. And with good enough, it's about being able to get information about the clinical effectiveness of an intervention, right? So does an intervention actually reduce the symptoms of depression or anxiety, to begin with, right? And then the second part is around this idea, of big enough. And so at big enough, you have to think about the context in which you're working. So to give a more concrete example, for example, in Kenya, and then maybe some parallels in Ukraine. So in Kenya, we generally have providers like psychiatrists and psychologists available, but only within urban centers and only within, kind of like clinics. So if you're building a model that heavily relies on providers' availability, that model is not big enough because it can't be scaled outside of, the urban centers in Kenya, right? And so similarly, obviously, I'm not a subject matter expert, that there might be some realities, for example, um, with like the war that is going on and the conflict in Ukraine, which means that when you're designing your intervention, you have to think of and put this context, in mind as you want to, like do that, right? So that becomes the second part of, thinking about, is this, like big enough, right? And then the last two is about simplicity. So who do you want to be able to use this? So if it's like a digital tool, is it simple enough for the end user to access it and to use it? In our case, if we're going to be training the government to build this three-tier model, governments generally require systems which are super simple. So is it simple enough for the government and the partners that we're working with to be able to implement on their own? And lastly, there are also elements of cost that we need to also like think about, right? And so basically the idea is, as you're putting together this stepped care model, beyond just thinking about the clinical effectiveness for the mental health problems, thinking about it from the perspective of like, does the model that I'm building work to solve the full scope of the problem and of the need, which, as I mentioned, is increasingly growing? Is it simple enough that other people can be able to, who I want to use it can use it, and is it cheap enough that it's actually, accessible? Because one of the challenges we have from a mental health perspective is that care is generally inaccessible because it costs, a lot of money, right? And so, at least in the context of Kenya, we're realizing that government and public health systems are the only quote unquote doers who can implement these stepped care models within a scale that it can serve the whole population. For example, governments already run schools, and we want to work in schools to reach young people. Government already have health systems which we can leverage for like referral and supervision, and for tier 2 and for tier 3, like care. So for us, it becomes important that rather than building a parallel system, we build something that can be integrated, into the existing, system, right? And so a big part of the thinking that we're now having is how do we design this stepped care model with our quote unquote ultimate doer in mind so they can have ownership over it. And so that's also just a challenge for us as we're thinking about this is if you're trying to design something which is going to be implemented in clinics or in community facilities or in schools, we have to think about that ecosystem, and we have to then design with the intention of eventually integrating and handing over this ecosystem to take over. And that requires obviously continuous learning and continuous iteration beyond just the evaluations that I talked about, like the randomized control trials, etc. It also requires us to think about how we can leverage real-time data we are getting from implementations, from sessions. We can put into place feedback loops to allow us to refine our protocols and to engage in, continuous and incremental improvements. And so lastly, and then I'll pause for questions, is about AI and what AI can do in supporting stepped care. And I think this is important for a couple of reasons. Just a minute. So the first is already a lot of young people are increasingly using AI tools as therapeutic agents, even if AI tools were not built to be therapeutic agents. I think that is already happening even in Kenya. And I do envision that continuing to happen. So we just can't, operate in a silo and not be aware of this, kind of like new emerging reality. And the second is at its current status, AI has a lot of potential in strengthening, but not replacing, at least in my opinion, but strengthening the human infrastructure of care, within the stepped care models. And it can do this in two broad ways. So the first part is around helping make providers effective. And what I mean by this is if you think about the recruitment, training, and supervision, for example, of tier one providers, there's a lot of potential there in using AI tools to help support supervision and training, right? And the second part is also with quality control as you're scaling, you want to monitor fidelity. And so there is, kind of like an opportunity, for AI to help supporting the training and supervision as well as the quality control, amongst providers. And then the second bucket is, as I mentioned earlier, we're increasingly having this broad range of treatments. And a big part of stepped care model requires triaging and matching people to different kind of like tools and different kind of providers and different kind of interventions. And so we can leverage into AI tools to help match people to different type of interventions. It may be that a kid benefits from growth mindset, or it may be that they benefit from interpersonal therapy. And so you want to be able to, kind of like match them, for those. And I think this is where we have the most potential because most of the AI tools in theory can already do something like this. And we've tried doing some of that with the training and supervision of lay providers, especially around fidelity. And one of the ways we do that is sampling some of the group sessions that they're doing, and taking them through that an AI model, which can then be used to like evaluate, how effective they are in following the clinical protocol, and can be used as part of like their supervision, processes. But it's still really weak, which makes sense because a lot of AI tools were not built for this type of approach. And it does well in basically making binary yes, no decisions, so like let's say active listening. Did the lay provider engage in active listening? Yes, no. Did they complete this activity? Yes, no. Did they cover this content? Yes, no. Like the AI tool does well in that. But it's really bad currently in understanding, quote unquote, the dynamics of therapy, right? So like the therapeutic rapport or alliance between the facilitator and the members of the group, the more like nuanced aspects, kind of like of therapy. And so, there is still a lot of work to be done there, but, more immediately in terms of just helping us, do yes, no decisions, and help support supervision and training. There is, like some, potential, there, as well. Yeah. And just to wrap up, as I mentioned, the reality today is young people already using tools like ChatGPT, chat character AI, etc., for emotional support globally. But these are unstructured, they're unsupervised. There's no, kind of like clinical guardrails. There's no monitoring, there's no escalation pathways, etc. But I do think that there's, for better for us is going to be the reality of the status quo as we move on, right? And so we need to also start thinking about this, as an opportunity of imagining how, this can work within a stepped care, model. And so what we are envisioning eventually is you could build some form of a stepped care model that incorporates, AI guided tools, both as entry-level psychoeducation tool, or as a screening tool or as a triaging tool. But you have to do it, like within a model that allows people to still access, diverse type of interventions, and diverse types of providers. Yeah, so just to wrap up, some of the takeaways from this is, we think stepped care works, and it does help solve the two main structural problems around not having enough providers, and a mismatch of interventions to context. From our work in Kenya, we do have evidence that, this type of approach works, and it can, provide clinically meaningful outcomes at scale at a fraction of the cost. There's an opportunity to think of AI as a multiplier, but only if it is built into the care infrastructure, intentionally, and not just as a standalone, tool. So thank you so much for listening, and I'll hand it over to Professor Jörg.
Yeah, thank you, Tom, for that very, very fascinating talk, and sorry for the problems. I hand over to Dr. Bulavinova just to read out the questions. And I was very impressed because since the last time we met, you now integrated AI as a chance to support your work. And that was very interesting for me today, because I think we often discuss these new technological things in a critical way and fear that quality can be diminished or that we can have problems. And this was very, very fascinating how you talked about including AI in training a big number of peer helpers or young helpers and young persons, and in assisting supervision of protocol adherence. So thank you. Excellent talk. Dr. Bulavina, are you here?
Я тут. Jörg, чи ви мене бачите, чи ви мене чуєте?
Now the picture is frozen. Do you hear me, Tom?
Я дуже добре, Jörg, вас чую. Чи ви мене бачите, чи ви мене чуєте? Бо зараз я бачу у Йорга і у Тома заморожена фотографія. Jörg, чи ви мене чуєте? Будь ласка,
I can hear you, but I don't. Tom,
Добре.
I saw him frozen and
Да, Том поки що
But I
замерз на
think
екрані.
back.
А, все, він
He's
повернувся.
back.
Він повернувся. Так, добре. Тоді продовжуємо з питаннями, які нам задавали слухачі. І так, перше питання від пані Ели Петренко. Які інтервенції роблять фахівці першого рівня?
Thank you. So just to repeat the question is what are the interventions that are done by the providers in the first tier? So they do two types of interventions. So the first one are very simple strength-based interventions. So an example, for example, is growth mindset. So teaching young people that they can, practice, like a growth mindset. Yeah, and I'll just maybe quickly share this one screen, which shows them. So as you can see here, so the fast tier delivers very brief, low touch interventions, which focus on building strengths and trying to improve human functioning. So the things like learning how to practice growth mindset, gratitude, sense of purpose, problem solving, etc. So that's the primary type of approach that they do, and then they're also taught to do things like psychoeducation, motivational approaches as well. But just to emphasize, they don't do the more clinical work like interpersonal therapy or cognitive therapy. That is for tier 2 and tier 3.
Так, тоді наступне питання. Його задали англійською, тому я його і зачитаю англійською, а перекладачі будуть перекладати навпаки. Мар'яна Бучаєвська питає: How do you determine the complexity of cases and which specialists handle this? What tools do you use for this?
Do you mind repeating the question? I think I lost it. How do you determine? Yeah.
How do you determine the complexity of cases and which specialists handle this? What tools do you use for this?
Yeah, so we generally do this in three buckets. So the first is we use screening tools, and the ones we use are the Patient and Health Questionnaire, PHQ-9 for depression, and the General Anxiety Disorder Screener, G87 for anxiety. So at baseline, when everyone signs up, like everyone completes this screener, and then from the screener, folks who have elevated symptoms are automatically referred to tier 2. So because tier 2 are folks who have some mental health background, most of the time a bachelor's degree in psychology, they're already trained as part of their training to be able to now do the full, like DSM type, screening and, kind of like risk assessment. So that's the first approach. The second approach that we use is self referral. So basically, we allow every young person who feels like they need more, they need more support to just like self, like refer. In addition to also, like training the, lay providers and tier 1 providers, kind of have some like, outlook, like around this. And as I mentioned, we've actually, and I'll just put the link on the chat, and it's like an open access article that goes into, like the full details of how we do implement this risk management protocol, and the different kind of like junctures of triaging and who kind of like handles that. If you're interested in like going into more details, right? But maybe just to quickly share this, which will be on the article, is there is like this flowchart here, which you can see on the article, which just goes through like the different, kind of like steps of the screening, what is being used around that, and who is responsible, kind of for what. Yes, I think just in the interest of time, I'll encourage you to click on the link on the chat and see the article.
Так, і є ще таке питання від пані Наталії Венедиктової. Чи співпрацюєте ви зі спеціалістами Дрезден Соломія? Вони зараз проводять цикл лекцій в Україні по ІПТ підлітковому.
Do we collaborate with who?
Дрезден Соломія.
No, I like residents, or no, I don't. Maybe if
Okay.
you can type
Okay.
it, the chat.
Окей. Тоді я дозволю собі задати декілька питань зі своєї сторони. Наприклад, Том, ви сказали, що підлітки вже використовують різні AI-tools зараз. Які вони? І які ви бачите в цьому ризики, а які бенефіти?
No, that's a really good question. That's a really important question. So, as I answered, I think just at least from my understanding of the context, one of the main issues is we have this treatment gap, and young people need emotional support, but they just either can't access providers, or it's too expensive for them. And I think one of the reasons why they end up using AI tools is because it's just more readily, kind of like available. So I think that's, in my opinion, is one of the reasons why, kind of like young people are using it. I think the challenge is, in my opinion, AI is not ready to be used as a therapeutic agent, and as an intervention. But it is being used, kind of like as an intervention. And the conflation comes in because AI can do simple things, like active listening, kind of helping you with like a problem solving, like framework, which is easy for people to sometimes conflate, with getting actual help. Like, I'm not saying those tools are not important. They are important, and they do, kind of like help people, but because AI can do that for a lot of young people, it then, kind of like sucks them into, kind of like believing that they're actually getting actual therapeutic, like support, from the AI tools. But because in the back end, the AI tools were not built as therapeutic agents, don't have effective guardrails, don't even know, kind of like the clinical efficacy. What happens not most of the time, but sometimes, is you have these extreme cases which have been on the news recently, from like suicide and self-harm, as the worst case scenario, etc. Right. So that's kind of the unfortunate part. Though when I look at it now from the perspective of like a social innovator working in this space, I draw parallels with AI to what has been happening over the last 10 to 20 years with digital interventions and, social media. And what we've seen over the last 10, 20 years is people are increasingly using digital tools both as a medium for accessing care, but also as care, kind of like itself. And so I will imagine something similar is going to be happening, with AI tools, right? And so with that in mind, kind of I do see the initial opportunity using the same parallel, with digital technologies is AI as a medium. So for example, now we have virtual therapy sessions and virtual, doctor, sessions, which, kind of we didn't have a few years ago. And in that way, technology has become a medium of, enhancing, like that care. And I do think the initial opportunity with AI is something similar. And so that's why for us initially, we are focusing a lot on training, supervision, etc., of providers and helping, providers become better, supporting with some of these questions that we were asked about triaging, and risk management and, kind of like flagging, different cases, so as a tool in supporting the therapeutic process, I think there is, kind of like a lot of immediate opportunity there for which a lot of AI tools can already do with some enhanced training, better prompting, better supervision, etc. And then finally, kind of now thinking about the bigger and longer term picture, assuming a new reality, where people are going to be increasingly relying on AI tools, how do we then find ways of effectively building AI tools as part of the care process, right? And that's why this idea that we are thinking of AI tools as just one step and maybe like a low touch step within a broader care continuum, makes sense in my opinion as an initial next step, right? So, and doing initial screening, triaging, etc. And then over time, building from there. Thank you.
І в мене є ще питання, якщо це можливо. Коли допомогу надають не спеціалісти, тобто допомогу на першому рівні, з вашого досвіду, чи багато там ризиків, що вони починають робити щось не те, що ви би хотіли, а щось дуже своє і можуть якийсь нанести ущерб людям, які отримують цю допомогу, підліткам, наприклад?
No, that's a real possibility, right? And that's why training and supervision, and especially supervision, becomes, really important. And so let me just talk about those two. So with training, one of the things that we want to do, and especially you have to do with tier one providers, is you have to standardize the sessions that they're doing, right? So you have to build a really rigid protocol that almost, maps out what they're doing from the beginning to the end of the session, including giving examples, where they have to give examples, giving them, kind of like content, like to talk about, and just really emphasizing this, during training, right? So the first way we try to deal with that is having a very rigid protocol around this to just make sure that you try to standardize this and really training people on this, but also supervision. And so we do supervision in one of three ways. So the first is we normally randomly sample some of the group sessions to include a supervisor to just like listen in and just make sure that the supervisors are the play providers are following the content. Second, at the end of every session, we normally collect, like, it's a very brief 5-item questionnaire, just like feedback responses. And normally you can use that to like flag, and third, all the lay providers are required to attend 1 hour one-on-one supervision session every week, as like part of this, right? So to answer, like your question. Yes, there is the potential, for doing this. But we think that you can solve for this with, effective training, and supervision. And I'll also just put a link to another article that we've written, which just goes, into the details of some of the strategies that we use for like training and supervision to deal with this issue that you have actually.
Тоді ще таке питання. Коли ми хочемо, щоб не спеціалісти займались спочатку людиною, наприклад, підлітком на першому рівні, з вашого досвіду на практиці, з того, що ви бачили, це збільшує чи зменшує потім потік на спеціалізовану допомогу? Чи нема такого ефекту, що потік на спеціалізовану допомогу ще стає більшим, що запит стає більшим?
Yeah, actually, that is the case. And we actually think it's a good thing, right? So because of stigma. So just to give a concrete example, when we go to schools for tier one care, we don't have an inclusion criteria. So basically, yes, we do the screening to help us with triaging, but any kid who wants to join in the school is allowed to join, the group sessions. And actually, in fact, we sometimes do find up to between 70 to 80% of the students join the group sessions, because some of them see it as like, it's an after school activity that they're doing with, like their friends and their classmates, etc. And the consequence of that is it actually does normalize. And we do find between 15 to 20% of the total participating group needs to be escalated to tier two and to tier three. And that actually does increase the number of people who need, kind of like help. But the reason why we see it as a good thing, at least in the context of Kenya, is because of stigma. Many of these people will not even be going to see the providers to begin with, right? And so at least creating an environment where you're normalizing and bringing access closer to people in a non-stigmatizing way, is like a good thing. And but obviously, for example, in our context, sometimes I think right now on average we have like a 4 to 6 week wait period before we can escalate people sometimes, which is just a consequence that we're having more people who are doing it. But we think that's a better problem to have than having the problem of people because of like stigma just not seeking help to begin with.
Йорк, хотіли б ви ще прокоментувати?
No, I completely agree with Tom, because in any way it's raising awareness in if you go to a classroom and if you have a focus on the problems of the kids, and if you can bring them in a service chain, I think for the professionals, it's also a relief that they don't have to care for that huge quantity of children around. Because when you started your talk, it was, I think, very important to say that we underserve the many kids we have that really are worried about their psychological situation and that look for help. So I don't see so much the risk of that approach. I think if you don't have good supervision, but to say the truth, if we look on that, what happens in psychotherapy in a rich country like Germany, we have no control what psychotherapists are doing with children. So if we talk about protocol adherence, you control that in the lay workers that you train. In our psychotherapists that really work in private practice and serve patients every day, we don't know what they are really doing with the patients. And you have no guarantee that they are conformed with the guidelines. So it's only the self-control of the profession. So I think that the problem that perhaps somebody does something that is problematic, that can also happen in psychotherapy. So what I think in your model is very important, that you have supervision, control, and also evaluation of the results. What we normally don't have in treatments that we administer to the population.
І в мене є ще останнє для сьогоднішнього ефіру питання для Тома. Коли ви, Том, почали говорити, ви сказали такий термін, і коли вас Jörg представляв, прозвучав такий термін, як соціальні інновації. Це не дуже розповсюджений термін для медичної громади в Україні. Тому хотіла вас попросити навести приклад якоїсь соціальної інновації, яка може описати це явище. Що це? Якийсь конкретний приклад такої інновації, який вам подобається.
No, thank you so much. And that's, kind of like a really good and important question. And so more broadly, when we think about social innovation, we are basically asking ourselves, how can we implement existing ideas, models, services more effectively to meet the needs of communities that are generally, kind of like underserved. And the difference between this and more traditional innovation, and in more traditional innovation, you're trying to either implement existing or new ideas, models, services with the aim of, kind of like building a company and making money from it. But with social innovation, the crux of what you're trying to optimize for is, like social, good, right? And so in the context of mental health and the context of Shamiri, we are like, there are ideas which already exist, and so one of those ideas is we have evidence-based therapies, like interpersonal therapy and cognitive behavioral therapy. We're increasingly also having this new quote-unquote strengths-based interventions, that teach resilience and build on, kind of character strengths. And these ideas generally are in academia, so to give an example of myself and how I got into this work, I was actually working at a lab at Harvard, and I thought I was actually going to be a professor. I think that was like the approach I was taking. But I was really frustrated in that we will do these great studies and would publish a paper in the journal and would move on, kind of like to, the next thing, and that just leave that great idea, within that journal. So from a social innovation lens, the question is, can we now take this idea and find a way of like implementing it in the real world to meet the social needs of as many people, as possible? And so if you look, for example, at the ideas that form the quote-unquote Shamiri model, none of them is like a new idea, like task shifting, as I mentioned, is a WHO approach that has been used a long time, training, develop these protocols, measuring fidelity, psychoeducation, all of these things, there's already a lot of literature from around the world, from research, from practice that is working. And so what we're just trying to do is, can we now put them together in a way that is implementable in the real world and can maximize, the the benefits for as many people, as possible, right? And so outside of just like mental health in other parts of in other parts of our day-to-day life. If you think, for example, about microfinance, so like giving out small loans, banks typically already give out loans to most people, but in most parts of the world, there is a group of people who cannot be able to, afford it, or don't have, collateral for a 10,000 euro, loan. But then you have these organizations that can give out like 100 euro, 200 euro, like small loans to like small farmers, for example, right? Or energy, in most parts of the world, you have electricity and you get a bill at the end of the month and you pay for that bill, but some people cannot be able to pay for that, right? So there are models which do, quote unquote, we call them pay as you go energy, so you pay 5 euros and use energy for 5 euros, and you continue like that, right? So that generally is the idea of kind of social innovation, where we are just like trying to take ideas, products, services, which are evidence-based, which work, generally in the world, but try to like think creatively and innovatively about how we can repackage it to solve the problem that most people, have, right? Which in the context of Kenya, young people can't access therapy because it's expensive, and there are not enough providers. And so the social innovation angle is, can we use ideas from medical practice, research practice, and package them in a way that, of course, doesn't solve the problem as much as it would if you are accessing like a psychiatrist, but goes a long way in expanding access and giving services to as many people as possible.
Дуже дякуємо Тому за цей вебінар. Він був дуже цікавий і, як завжди, дуже дякуємо пану Йоргу Фегерту і пані Оксані Збітнєвої за підтримку нашої ініціативи. І всім тихого вечора, наскільки це буде можливо в Україні сьогодні. Всім дякуємо, що ви до нас приєдналися. Ще раз нагадую, що запис українською вже є на каналі доктора Булавінова, запис англійською буде викладено скоро, і ви його теж побачите на цьому каналі, тому підписуйтесь, будь ласка, на канал доктора Булавінова. Всім дуже дякуємо, що нас дивились. Дякую, Йорг, дякую, Том.
Thank you. Thank you.
Thank you. Bye.
Take care. Bye.